So we're going to start today by listening to or having presentation by Cody Mayer. She's with the Davis County Health Epidemiologist Department, and she's going to provide an overview of caregiving specific to Davis County, because that is our topic today, is caregiving and how you can best support that process. After Cody, going to introduce an illustrious panel that we have today, who's going to speak to us specifically about an area of caregiving that I don't think we're well aware of, but probably need to be more so. So, Cody, can I go ahead and turn that over to you?
Yes. Let me share. See if it goes. Can't share your screen. Let me try again.
And Cody's so glad that she's the one that gets to work out the kinks here. Thank you, Cody. Thank you.
We see the presentation, I think.
Yes, we do.
Okay. Okay, so like she said, my name is Cody Meyer. I am an epidemiologist with the Davis County Health Department, and I'm just going to talk to you guys about some caregiver data that we have specific to Davis County that was in our 2023 Community Health Assessment, also known as the CHA. So I'm just going to dive into that. I first wanted to highlight where you can find caregiver data in the CHA. I want to note that those who provide childcare are also considered caregivers as well, but it's not often the same type of caregiver that we mean in our work. But we have one page of childcare data in the CHA, and that's on 246. And this page highlights the benefits of having affordable childcare as far as the return on investment for the economy and directly for parents and children who receive it. And it also notes the lack of affordability and availability in Davis County. And then the caregiver section is right after that, and it starts on pages, it's from pages 247 to 249. And that's the data that I'm going to share with you all today. So I want to start with how we define caregivers in the CHA, and that is adults who provide unpaid assistance to family and friends of any age with health conditions or disabilities to help them take care of themselves. And this page is just Utah in general. The Kim C. Gardner Policy Institute found that Utah caregivers, especially those who are also raising children, have worse mental and physical health outcomes compared to non-caregivers. The demand for caregivers is expected to increase faster than population growth by 2030, meaning that more Utah adults will require time, resources, and mental and physical health support to provide that care. And this is in part due to the aging baby boomer population and healthcare shortages. And then this quote is directly from the CHA. In Utah, 1 in 5 adults identifies as a caregiver, providing an average of 832 hours, care hours each per year, which is equal to $5.1 billion of unpaid services. And that is likely an underestimate because many people just see themselves as a good family member, friend, or neighbor. And so now I'm going to dive into the Davis County specifics. In 2022, 20.1% of adults identified as a caregiver for a family or friend with a health condition or disability. Of those, 86.5% managed household tasks and 43.5% managed personal care. A majority, this is Davis County caregiver characteristics and disparities. A majority of those who identify as caregivers are female. They are under the age of 50 and they make $50,000 or more per year. But there is an unfair burden on females, those over the age of 50 and those who make $50,000 or less annually. And just what that means is about half of our population is female, but 61.5 or 61.3% of caregivers are female. People aged 35.9% of the county population are over the age of 50, but almost half of caregivers are over the age of 50. And then people making $50,000 or less annually at the county level, that's about 27.8%, but 35.3% of caregivers in Davis County make $50,000 or less annually. And then specific to Davis County recipients of care, so those who are receiving care, the most common person would be someone caring for a parent or a parent-in-law. Number one of that is the care of a biological mother. And then caring for a child is twice as common in Davis County as it is in the US. Among those who specified a health condition as the reason of care, advanced age was the most common reason, and mental illness was twice as common in Davis County as it was compared to the state and the nation. When asked about frequency of care, the majority of Davis County caregivers reported providing 8 hours or less of care per week. Nearly 1 in 5 caregivers in Davis County reported providing 40 or more hours per week, as compared to 1.6 or 1 in 6 for Utah caregivers. And then as far as duration goes, over half of the caregivers had provided care for more than 2 years, and about 29% had been providing care for less than 6 months. And then throughout the CHA, we have these resource tables, and this is just a table of the local and state resources for caregivers that we had at the time the CHA was released. I would say if you know of any others to add to the resource directory, let Travis know, and he can get that information passed along so that we can continue to build on the resource directory that we have. And that is what I have for you guys. So thanks.
Cody, thank you. Does anybody have any questions? I see we have a hand raised. Is that you, Rochelle? Rochelle, did you have a question you want to ask Cody?
Cody, I was just going to have you click on the link while you were sharing. Just to briefly show our newest report that came from the CHA, but it dug a little bit deeper just on caregiving for older adults, which I know Shauna will present on some of those resources. But when Cody's talking about data that's available, this particular one pager is also available. But
where is that on the website?
Oh, I gave the link just under reports. The new reports
in there in the chat. The link's in the chat. Is that what you said?
See. Yeah.
And for those of you that have not had a chance to look at the CHA, I would strongly encourage you to go through that document, see how it pertains to your work. There's such valuable information in there. So there it is, Senior Service Division.
So some of that data is updated now.
Thank you.
This is even more.
The link as well, the shortened one. So it's cha.davis.org.
Mm-hmm.
Valuable document for Davis County. Cody, thank you so much for giving that overview about caregiving in Davis County. A lot of those statistics I had not really seen yet, so I appreciate that you did that. Thanks, Cody.
You're welcome.
So now we're going to move on to a panel that we have for you today. We have a panel of professionals that we have connected with through the Bateman Horn Center. And the Bateman Horn Center is a nonprofit in Salt Lake, but the individuals that you're going to hear from today are from all over in their expertise. And we really appreciate them being here. So I'm just going to go through briefly, tell you who's here, and then we'll let the panel kind of assemble themselves. I don't know if this happens in Google Meet. I know that in Zoom, if you raise your virtual hand, you go to the top of the page. Then we see everybody in one string, but I don't know if that actually works. But we have Talia. I'm going to butcher your last name. I'm so sorry. I should have asked you beforehand. But Talia is the executive director and education director at the Bateman Horn Center. We'll give you more introduction about her as we move into the panel. We have Melanie Hoppers. She is a physician at the Bateman Horn Center. I forgot to tell you that Talia is a young adult sister with, I'm going to pronounce this, I'm going to do it right because I practiced it, myalgic encephalomyelitis. And I know you probably don't know what that is yet, but you will, and you'll understand how debilitating it can be and what kind of caregiving supports are needed for that. We also have Amy Mooney. Amy is an occupational therapist through the Bateman Horn Center. And then we have Galen Warden. She is a mother and an advocate. She has an adult son with a very severe form of this disability. And so we have her here also to talk to us. And that is our panel, unless I've missed anybody, Travis. I don't think I have. But with that, I'd like to point out that I think we can all see you now. Thank you. And I have some specific questions to ask each of you. And if you wouldn't mind answering them in this order, I'd appreciate it. If we could start with, because Talia's at the top of my list. Here's the first question. Can you please provide a background of what the Bateman Horn Center is and how this organization supports caregivers?
Absolutely. And Deb, we have a little bit of a presentation that kind of, we tried to cover a fair amount of the panel questions and some of this background. If I may, I'm going to start there, and then what's left, we would be more than happy to engage with. So let's hope that I can do this correctly. I'm going to share this PowerPoint. Do you all see the full screen? Yes.
Yes,
okay,
we
that worked. Okay. So, we've already met the team here. They are a wonderful, wonderful group of caregivers, and I'm so lucky to have them in my corner working with me. We're going to start by having each of us introduce kind of our why, our loved one, and why we are a caregiver for them, and just a little bit of background. So I'm going to start with Dr. Hoppers.
All right. So I'm Melanie Hoppers. I'm an internal medicine and pediatrics physician. This is my daughter, Sarah. She was 10 years old when she developed mono, and she went from being this happy social butterfly to this person who's, very ill. And, that's bad enough. But as I was thinking about it one day, I thought, as bad as it is for Sarah, she has me. She has me as a physician to navigate through everything. And it's still quite hard, don't get me wrong. But sometimes doors are opened a little quicker. And I realized there are kids and there's adults too who don't have care. So I reached out to the Bateman Horn Center. They helped me getting Sarah diagnosed and all of this stuff. I mean, I'm in Tennessee, by the way. And this is your gym in Utah that you have, this great, fabulous resource. I had to go to Utah to get help for her. And so thank you, Utah. It's a great state. But in my process of getting help for her, I realized that we needed more help everywhere. And so I converted what I was doing in my practice to seeing patients with myalgic encephalitis and now long COVID, of course. And so that's my why.
I am Galen Warden, and can you hear me? I had to unmute myself. So this is my son, James. He was just as her daughter was, a vibrant, healthy young man. He also got mono. He has long mono, if you want to think of it that way. Myalgic encephalomyelitis is a infectious disease most of the time. And he slowly became more and more and more debilitated over a 10-year period because no one recognized what was going on with him. He showed up to doctors, weighing 113 pounds at 5'10", saying he was too exhausted to prepare food for himself or to care for himself. And the doctors gave him therapy, mental health therapy. They didn't recognize this major symptom of this disease that has been known for a long time. So, he was desperate to get better. So he did what they said, and he exercised and lifted weights until he became bedbound. So my point, really my reason for becoming an advocate is it was pure ignorance that made my son this severe, and I don't want that to happen to anybody else. So we're here to spread awareness.
And I am Amy Mooney. I'm an occupational therapist. I'm also the mother of 3 children. My middle child, Lizzie, was 9 years old when she first became ill with something we don't even know. It was just identified as she's going to get better. She's got some random childhood virus or something. So we just spent time waiting for it to get better. And we are now 10 years into this, and she has never resumed her health. So 4th grade was the last time she was last really in public. She is an amazing child. She has made everything of her life super impactful, but her symptoms are very, very severe. And when people say this is just, a fatigue, this is something that you're exhausted, I want the public to know that this is symptoms that you feel like you are hit by a bus, you've run a marathon, you have the worst flu and a hangover that you all can experience happening one at a time. We usually think of it happening one at a time, but this happens in a huge hurricane towards a person, and especially to a child, it is unimaginable. So as an occupational therapist, I have looked at, how to make my child as functional as possible in this life that she is living. But my mission is to change occupational therapy and say that it is not about the type of effort and exertion they present to you in clinic. It is actually how they recover from their getting up to go to the bathroom. It is the pieces in between their exertion that I need to focus on with my people. and that's where this is meaningful to me as a caregiver, because it was 10 years of blood, sweat, and tears. So
Thank you, Amy and Galen and Dr. Hoppers. This is my why. So I actually started as a caregiver really young. My father also has a lot of the unexplained diseases, which I also now know as ME/CFS and the comorbid conditions that go with it. He was met with a ton of disbelief. Being a man, trying to navigate this, he had applied for disability and was denied because this is more of a woman's disease. So when I saw my sister starting to go down a similar path with her health, it was almost like a cascade of terrible events that happened: a car accident, a viral infection, and a weightlifting accident. And all of that completely changed her life. We live in Colorado, and so it was really hard to see her bouncing around all the different specialties. I worked in acute rehab in a hospital, and I couldn't get her connected to the people to help her. She walked away in that process with a bipolar disorder labeled on her, depression, anxiety. They were trying to throw a conversion disorder at her, and I said, that's it. Like, we're getting out of here. We have to stop seeing these specialists. It's causing so much harm to her and how she sees herself at the end of the day. I moved to Utah, and I was working at the University of Utah running Project Echo. And I met Dr. Lucinda Bateman, the founder and chief medical officer of the Bateman Horn Center. And in that one lecture that she gave on ME/CFS, it all the unexplainable became explained. And I thought, this is it. Like, I actually have an answer for them. So I joined BHC in 2019. And it's really been my mission since being here to make sure that the Lizzies and the Sarahs and the Jameses and Savannahs out there get seen. They get the care that they need. They don't get bounced around, because at the end of the day, we don't have a medical system that provides the space and training for these providers to meet these patients' needs. And in that, these patients and their families and their caregivers are falling by the wayside. And so as a caregiver, trying to advocate and help her navigate through all of this, even with my background and knowledge in healthcare, it's incredibly impossible. And so we just have to do better. And I'm hoping that you all today can help us be a part of that. So getting into really what is the Bateman Horn Center. We are a 501c3. We're a nonprofit. We mainly focus on clinical care, research, and education, both medical and patient education of post-infectious syndrome. So you'll hear us talk about myalgic encephalomyelitis or chronic fatigue syndrome, ME/CFS. Sometimes you'll hear us bounce between saying ME/CFS or ME, fibromyalgia. We've really focused our attention on long COVID and PASC because ME is really that blueprint for what we do with post-COVID ME/CFS. And we also serve patients with all their comorbid conditions. You likely have heard of POTS and small fiber and mast cell and connective tissue disorders. So I'm going to turn the time over to Dr. Hoppers to tell you a little bit more about what ME/CFS is.
Great. Thank you so much. You've said a bunch of things that I think I wanted to say, so yay. So one thing, I just want to say thank you for being here and thank you for doing what you do. It's so important, and I don't get the chance to say thank you very often, so thank you. So as Talia said, I'm going to call it ME/CFS so I don't bungle it, because sometimes when I talk fast I do. So ME/CFS is a chronic, complex, debilitating multi-system illness. To highlight that point, 75% of people with ME/CFS are disabled or cannot work a complete work schedule. 25% are homebound or bedbound. And then kind of echoing what Cody said earlier about the statistics for family members, there was a study that was done in 21 that showed the quality of life scores of people with ME/CFS. So this is for the family that's taking care of them. I'm going to see if I can, I just exited out. Anyway, the quality of life scores were significantly decreased in patients who had family members that they were taking care of with ME/CFS. And some of the things were the anxiety, sadness, and worry about their family member. And then, of course, the quality of life scores for patients were done as well. And it was found that patients with ME/CFS have lower quality of life than patients with multiple sclerosis, cystic fibrosis, and cancer. And actually, it was the lowest score of all. So anything you can think of, ME/CFS had lower scores. And I think that kind of just tells you at the beginning what a significant disease this is. And like I said all those words. It's chronic, complex, debilitating. And what that results in, it results from the fact that so many parts of the body are affected by this disease. It is a neurological disorder. It affects both the brain and the peripheral nervous system, but it also affects the circulatory system, the heart, the circulation. There's impaired cellular metabolism. And I won't try to teach you all about ME/CFS. It's like throwing, a million things at you, but I just want you to get the basics of it. But in their impaired cellular metabolism, they cannot produce energy. There was a study that showed patients that did an exercise test, and people who were deconditioned but healthy were recovered in a day. People that had ME/CFS, 0 had recovered in a day. So, just a comparison between a normal person and a not normal person kind of gives you a little bit of background on that. They also have immune system issues. And to have ME/CFS, there's certain requirements for the diagnosis. And one of those is that you have a loss of functional ability. So this person, it's not someone who's been sick all their life. It's someone who is just healthy, normal, living their best life, and out of the blue, now they can't do the things that they used to do. So there's a change in their abilities. It's not that they've always been like this, and I've come to believe, I don't really think people are inherently lazy, but so many people with ME/CFS get accused of they're just too lazy. They just don't want to do it. If they wanted bad enough, they could get up and go. I don't know where this comes from, because people with diabetes aren't told, well, if you just tried harder, your sugar would be lower. Now, granted, if you're eating ding dongs all day, that might be the problem. But, we don't accuse people when they have cancer that they aren't, trying their chemo harder. Anyway, so there's a functional decline. It's associated with fatigue. So fatigue is part of the illness, but it's not all of the illness. So their fatigue is unrelieved by rest. And so a person who has ME/CFS can be very tired. They rest. They may go sleep for 12 hours. They get up and they feel exactly like they did when they went to sleep. They have a disordered sleep as well. Their sleep is not functional. They don't get into deep sleep. And so it's not a restful sleep. So that's part of the disease process. They also many people have brain fog. You probably have all heard of that since long COVID has become a thing. We all kind of are familiar with brain fog. Most people have that, or they have orthostatic intolerance. Orthostatic intolerance you may not have heard of, but essentially it's where when people are upright, whether they're sitting, they're standing, or they're walking, their symptoms get worse. And it's because of their circulatory problem. They aren't able to get blood flow where it needs to go. And so they just can't stand up for very long. They'll get palpitations, blurry vision, they'll get lightheaded. They may even pass out. One type of orthostatic intolerance is POTS, and you may have heard of that. So I'll just throw that out there because you may have be familiar with that. So next slide. So as has been mentioned earlier by several people, ME/CFS, like I said, there's a normal person who's healthy, doing things, living their life, and then something happens. There's some sort of a trigger, and it could be an infectious trigger. Frequently it is. Frequently it's a virus. That's why COVID has left so many people with ME/CFS now. So COVID can do it. The flu can do it. Mono, again, my daughter and Galen's son were both patients with mono. Mono is a bad bug. Also, again, this is not just the United States. It's a problem for the United States. It's everywhere. You look at the list here: dengue fever, malaria. Those are things that can cause it in other countries. Also, some bacterial illnesses can do it. Trauma can do it. A whiplash injury. Again, the weightlifting injury can contribute. People who are hypermobile are more predisposed to that. So if they have an injury, it may lead to this. Head trauma and surgery. Sometimes surgery can. And sometimes we don't know. Like with Amy's daughter, we don't know what it was, but something happened. So those are the triggers that can do it. Next slide. So one of the unique features of ME/CFS is something called post-exertional malaise. And this is something that I've really focused on a lot lately, because as with Galen's son, the harm that was done, goodness, that story just really hurt me. But post-exertional malaise is, and I'm trying to break this down into something that's just, again, I don't want to give you too much information, but basically, patients with ME/CFS already have a reduced function. They have fatigue, they have pains, they have myalgias, but when they exert themselves, and this exertion can be physical, it can be cognitive. It could be just working on the computer for an hour or two. It could be social, interacting with people. It can be environmental, which are sounds, lights, smells. All of these things can be triggers, but when they have an exertion, then they have what we call a crash, or there's repercussions for that exertion. And those repercussions oftentimes are delayed. It may be 24 hours before this happens, and the recovery from it can be days, weeks, or months, or even years. And what happens is the patient develops symptoms such as the flu. They may feel, often when my daughter first got sick, we were constantly up at the clinic swabbing her for flu, strep, and, well, not COVID, because there wasn't COVID then, but flu and strep. We constantly thought she had flu or strep. She would feel achy, have a sore throat, swollen lymph glands, maybe a little bit of fever, and just couldn't get out of bed. Some people, their sleep disorders get worse. So some people can't fall asleep, even though they're extremely exhausted. They're wired up and they can't sleep and rest. And that's an exceptionally miserable experience when you're so fatigued that you can't even read a book or think or have a conversation, but you can't rest. And so that's a particularly miserable aspect. Some people become hypersomnolent. My child would literally sleep for 2 days straight. She would get up and go to the bathroom, but I'd do signs of life checks, seriously, go in and check every so often and make sure she is indeed breathing, because I didn't know when she was going to get up. They also will have worsening of their cognition. So they may have trouble thinking, they may have trouble processing, trouble having conversations. And again, the fatigue in PIM is really horrific. They may be bedbound. I have one patient who had quite a bit of exertion with graduation from school, and then she went on a family vacation, and she was kind of a mild to moderate patient, and she's still in bed, and it's been 2 years. She became bedbound after that trip, and it's 2 years later. So I can't express to you how ill these patients are. And also, it will seem ridiculous if you go into a home and they say, well, please speak in a whisper, please don't, make a lot of sound, please don't wear perfume. It seems like, oh, good grief. But it's true that this will harm the person. And the more a patient is in post-exertional malaise, there's neurobiological reasons for this, but basically it causes a worsening of their baseline, a worsening of their already lowered baseline. So every time they experience this, they're potentially going to become worse. So it's really important, it's vital, it's life-saving to do what you can to lower the exertional expense that the person incurs when you're in their home. So for those of you who do home visits or things like that. Now, Amy, I've already kind of gone over that slide. This is just a list of some of the things that can happen in post-exertional malaise. And I think I've kind of gone through that.
So this piece, though, I would like to start with, because when we look at severities and we categorize MECFS, or ME as I call it, typically in 4 categories: mild, moderate, severe, and very severe. And if we can go back one slide, I want to say that probably all of the patients have these symptoms and 70 more symptoms, but it's all individualized. So some people might have difficulty with cognition, but they can walk around the block. Somebody else might have difficulty when weather changes and their POTS gets worse, or their GI gets worse. So it just makes you understand that this is a multi-system disease, and some people have highlighted maybe more neurological, or maybe some people have more cognitive impairment. So these symptoms, if you are more severe, you are going to have the worsening of these symptoms. They're more intense. But people, even in the mild category, will say that I have 20 symptoms, and on certain days, certain things jump out even heavier. So I just want to highlight that these symptoms are not pulled out of the blue, and they are not people being, just making it up to get attention. These are very, very serious parts of this individual's life that, in the big picture, as an OT, I'm looking at what it does to your function. And when somebody has brain fog, they are not going to be as available for educational learning. So for students, this is really important to say, this child has had, poor sleep for the last 4 months. Well, what does that actually do for somebody that's in the school? And how does this person who has muscle aches and pains, how do they get around the building? And that's where I want just everybody to understand that these symptoms wax and wane. And 1 week it might look like the difficulty thinking part is their main symptom. Well, next week, something else comes up, and they're highlighting that they feel more fluish. So those are not made up, but they are really part of the diagnosis, as being worsening as the day goes on, or even the year. These things, when we talk about PEM, post-exertional malaise, as soon as anybody does an exertion or a stressor, these symptoms come and hit you like a bus. That's what we're talking about. It is not necessarily that they have, difficulty with transitioning to sleep, but actually after they do something or even have a bowel movement, they actually are wired and tired, and their body is going through a whole system of experiences. So that's what PEM looks like. Can move to the next slide.
So as we move into the next slide, I just want everyone to kind of keep in mind that as we're going through the spectrum of this, you can see that caregiver role in each of it and the needs that often we have to provide or that individual has to advocate for based on the various aspects of their severity and their illness.
So somebody that is mild will mainly need help with accessing materials. They're able to do some self-care activities, but they're probably not going to be able to do higher functioning instrumental activities of daily living. They can take care of themselves, but they're not able to maybe manage their finances or do some of the extra school work that are jobs of what a child needs to do. So that's mild. That's somebody that is just barely on the radar, and they're already needing a lot of support. And the next slide is moderate. And this is my daughter in the top left corner with her tutor. She was not able to go to school. She could do 2 hours, or not even 2 hours, 2 sessions of tutoring a week. And that was maybe for 10 or 15 minutes. And she needed all of her materials. She needed somebody to dictate and help her scribe all of her materials. So this is somebody that's trying hard to learn math when their brain is not computing. It just does not make that next connection. So they are needing a lot of assistance just to get a meal prepared. What I came into the kitchen, what was I doing? How do I finish this task? They are, trying to do the dishes, and they cannot get through this normal activity. And that's where I want caregivers to realize these are not people that are trying to avoid work. They are not trying to avoid learning. They are truly sick, and that they are needing as much support so that they can do meaningful quality work in their lives. Doing the dishes is not going to be somebody's high point of their week. It might be more, like, let's just somebody else do the dishes so this person can have a conversation with a loved one. It is not about doing menial tasks of the day. So get to the core parts of what is important for this person so that their quality of life can improve. And then severe is people that are bedbound. They are not going out of the house. They need full support in the caregiving. They can maybe get to the bathroom, but they probably on bad days need a bedpan, or they need a commode in their room. So they're going to need help with all of these activities so that they, like I said before, they can get to that quality part of their day that makes them feel meaningful and happy, whatever that looks like for this new redefined person that they are. And then very severe are the people that are like our kids at times, where they are needing feeding assistance. They are needing bedpans and catheters, and they are needing home health aides because there is absolutely no way that they can get blood drawn for a test. They need help coming into their home for everything. Or if they are hospitalized, think about how stimulating a hospital is. Lights, sounds, everything. That is a stressor. The body is under attack 24/7 when you are in a hospital. How can you set up a care center that has dimmed lights, and where hospital staff doesn't come in and flip on the lights right away to startle a person coming in, and that heart rate change for a person that has POTS won't settle down for days. It is just like a shock to the entire system by just turning on lights. So I think just understanding how sensitive and severe patients can be, and a person can be mild or moderate, and with one trip to a doctor's office, they are set back months and years. So how can we make our providers understand, you know, if we're caregivers to family members or if we're caregivers as a professional role, how can we set up their environment so that their body is less taxed, it's less stressful and straining. So things like that is what I spend all of my day thinking about for my daughter. How can I get her the needs, like the actual nugget of information that this doctor needs without taking her out of the home? It's possible, but it takes a lot of my energy just to try to figure out who can I contact? How can I get all of the information that is needed for her care? And that's how I think, like Melanie had said, I'm proud I'm my daughter's caregiver because I think I have been educated just to be able to take care of my daughter. So that's where I really, really hope that that all of you listening to this this panel can understand that parents are trying to do their best with limited resources. Not everybody understands medical situations. So if you are a medical provider, please step up and help that family.
So I'm going to talk about how everything that you're learning is going to impact you as somebody in society, whether you're a healthcare professional or whatever your role is. 6.8% of US adults reported having long COVID, which is about 20 million Americans. Long COVID presents itself in various ways, but studies show that 50% of people with long COVID meet the criteria for myalgic encephalomyelitis. I'm just going to say ME. That's 10 million Americans with post-COVID ME. Before COVID, we already had 3 million adults in the US with ME, in spite of the fact that many people never get a diagnosis. That's a number that they came up with. So if we do the math, that's 13 million people in the US with either post-COVID or post-mono or post-something trauma ME. 13 million Americans that are showing up in doctors' offices saying, what the heck is wrong with me? Why can't I stand in my kitchen and make my dinner? Why can't I, get to my job and function normally? I can only last about an hour at my job. And then I have to go home exhausted. What's wrong? And these medical professionals need to become aware, the society needs to become aware that the best thing you can tell these people is go home and go to bed. You need to rest. You need to radically rest. And because for 10 years, my son's symptoms were not recognized and he was told to work harder, then you'll be able to sleep. He couldn't sleep. He had insomnia. One time, he was awake for 7 days straight, talking about a sleep disorder. He slept 2 one-hour periods in 7 days. If you can imagine the frustration, the tears, the whatever. But I'm sorry, that was just kind of an interjection there. But these people are not getting recognized or seen. And we went to the hospital with this. And of course, they told him that he needed mental health support. And all the blood tests were normal. The urine test was normal. There's nothing wrong with him. We got to get past that. And I would like to, help you feel empowered today with all of this knowledge to become someone who recognizes these symptoms for now. Oh, okay, you had COVID or you had mono and now you're feeling like this. Okay, I know what to do with you now because of all of this information.
So Galen, while you have the floor here, I'm going to go to your additional slides, and if
Okay.
you could just highlight a little bit some of the challenges that we face as caregivers in supporting our loved ones or even our patients, right?
Yeah.
From that mild to very severe spectrum, there's opportunity within all of that. So I'm gonna tee you up for that.
Okay. So let's go past this. We're going to come back to this. Let's go to the third one. There you go. So here, just to get you a picture, the diagnosis was done at Mount Sinai in New York. That's my son standing for 10 minutes, and he was already a bedbound person, but he could get to the toilet using an office chair with wheels. He would scoot himself to the bathroom. They made him stand for 10 minutes and test his oxygen and everything. And so he got his diagnosis. And, pretty soon after that, he was bedbound and he needed non-urgent gurney transportation to get to any medical appointments. And at his medical visits, he had to keep his headphones on, his eye mask on to protect him from light. But my main point here, based on the question I was just asked, is we had no idea. We had a diagnosis, but we had no idea how to care for someone that couldn't get in a wheelchair anymore, that couldn't sit in a car anymore. And I tried everything. I even offered one doctor $600 to come to our house and see my son. My son had a seizure, and we had no way to get him to a neurologist. You know what gave him a seizure? The dog barked. That sound gave my son a 45-minute non-epileptic seizure. It was horrific. But we learned, okay, protect him from sounds. Okay, now that's one more thing we've got to do. But my point is, it took 6 months for me to learn about South Carolina house calls. I live in South Carolina, where a nurse comes to the house and she can check on him. We can get portable EKG and ultrasound and all these different services, not dental, but labs, everything in the home. It took me 6 months to learn about this because none of the medical providers I reached out to knew about it. The same thing with his teeth. He had a broken tooth and an infected tooth for 1 year before he got to a dentist. And none of the dentists told us about an hour and a half away at the Medical University, Hospital of South Carolina. There was a dental clinic at the dental school where he could get general anesthesia to be taken care of with his dental problems. It took us a year to get there. So imagine having an infected tooth for a year, multiple rounds of antibiotics, having a broken tooth with that putty that you stick on it for a year, not a week, not 2 weeks, not, oh my God, he can't get me in for a month. He spent a year with that agony because none of the dentists that I reached out to knew about this dental clinic. So when I saw your resources page, I was thrilled. Please look into what can we do for patients that are bedbound that we can add to that list. Something like general anesthesia for a dental cleaning, that's unheard of. Who needs that? These people need that. So wherever you can find, those resources, that would be awesome. Can you go back now? So these are the accommodations that a severe ME person needs. I've lightened this photo a lot. You can see the red light back there, but actually this is in a very dark room. He doesn't have an eye mask on, but he does have the headphones. He can't hear birds tweeting outside. The cicadas right now cause pain. This all causes pain in his brain. So these are just, some of the things I've made on this little diagram to explain the severe sensitivities that these, people experience, and the result of this kind of, I call it input, whether it's cognitive, emotional, or sensory, or physical, anything coming into them. Hearing a sound, trying to watch the TV, trying to listen to music, it causes pain in his brain. And now you can go up to the first one. This is what that looks like. This is called single photon emission computed tomography, SPECT. A doctor named Byron Hyde created this amazing document, which I would encourage you to go check out. I have a website, galenwarden.com. And if you go to /resources and scroll down, you'll see this image. There's his PDF is there. I didn't make the PDF. Dr. Hyde made it. And he describes ME. This is one image of a person with ME, their brain. And he's highlighted the different areas and he talks about it in the PDF. This area has this problem and causes these symptoms. So when all these people that you've just heard from are talking about organ systems and circulatory systems and all of that, it's all related to the brain. Our central nervous system commands the function of all of our body symptoms. So when your central nervous system is affected, everything is affected. And so what these areas are showing is low blood flow on a microvascular level. So this will never show up in a standard CT or MRI, never. But this is microvascular neuron impairment caused by poor blood flow. Researchers demonstrated that circulatory dysfunction provokes an unusually slow recovery of brain function, lasting as long as a week after any intellectual, physical, or emotional activity. So I hope you will go download that PDF and look into this because it's exciting to see that there's a physical way to actually see what ME is doing to people, because everybody says, oh, it's in your head. Well, yeah, it is actually in your head, but it's physically in your brain. And that's why the brain hurts. And they have these amazing feelings like, you know, they want to die because of this pain. So I wanted to talk about something else, but I can do that after someone, if you want, Talia.
Yeah, I just want to be mindful of time
Yes,
and
exactly.
because I'm not quite sure where we're at, but I wanted to just kind of bring all this full circle
Okay.
in saying that we put a lot of information out there, largely because without understanding a little bit of it, it's hard to get it. And it's hard to actually know how to support these patients. So we've shown you this huge spectrum, not only in what happens physiologically inside these patients, but how it can manifest, right? From mild to very severe. And there are touch points in that entire spectrum that all of us should be helping with, and in helping the patient with living accommodations, school accommodations, work accommodations, home modifications and accommodations. Helping people there means you're helping their care network around them. You're helping people like us be able to then focus on still having our relationship with them and not have to constantly be changing roles, right? And chronic illness strikes any of us at any time. And as you've seen, those numbers are pretty stark. We're seeing this more and more and more, and we need more help for these patients so that they can maintain some semblance of their life, they can maintain function, and they can also maintain their relationships with their caregivers. I think one of the biggest challenges and struggles is knowing how to help. And I'll tell you this, if you just ask them, they already know what they need. They know that they need, I just need some help, you know, getting my legs propped up or work accommodation so I can maintain employment, so that I can maintain my health insurance so I can afford my health care, right? It's this terrible, terrible, vicious cycle. But so I just want to kind of bring that full circle and say that we have a lot of these tools on the Bateman Horn website, tools to help support caregivers in caring for their loved ones. Communication cards, as Galen and Amy have shown, when the patient's really severe like that, helping them to communicate in a way that is very low stimulation is huge. Even for like my sister who's moderate to severe, when she's in a crash, one, watch out, because you don't really, she's not her best self, and understandably so, but it's hard for her to put into words what she needs. So having that set up in advance, that can be helpful. We have other guides and resources that are a resource to you to help in sharing with those that you come across.
For that wrap up. You actually have made this very easy to facilitate because your slides really dug into the questions that we really wanted answers for. And I appreciate the resource about your website, because I know that this group, I mean, I'm amazed. I had no idea about this information. And it makes me wonder how many times I've seen this and not recognized it. So thank you for that overview and for the website that we can go to so that we can know how to help support caregivers. Because obviously that is an area of strength that we can maybe help provide. Thank you so much.
I just
Go ahead. Go ahead, Travis.
put the link to the Bateman Horn Center for those that are interested. I think it'd be good if we could open it up for a couple of questions.
Sure.
We have until 9:30-ish.
Yeah. Do we have any questions?
I think Talia is putting more links.
Excellent. Yeah, there's lots of resources in the chat. Take a look. Okay. Oh, yeah, here's some more resources. This panel is obviously very knowledgeable. Is there anyone hearing this that has some specific questions that you'd like to ask?
So it looks like we have a question.
Oh, good, Travis. I don't see it. Go ahead.
Yeah,
Oh, yeah, there
so
you go.
someone asked, what does mental health look like for this particular population?
Yeah.
I would love to answer that if no one minds. Actually, that was my main topic I was going to talk about today, but there's so much information we want to share. So this population has suffered a severe trauma. The caregivers have also. So the patient has the trauma of losing their meaning for life. I mean, they may identify as a musician or an athlete or a hiker, and now all of a sudden that's all taken away. And this is mentally devastating. So you're dealing with a population that swings from like grieving what they've lost, to rage, an outrage you just can't even imagine, because they're furious that this has happened to them. This should not have happened to me is what everybody feels, because it's just, not fair. My son struggles constantly with the idea of, what is he living for? Why am I here in this bed? 5 years, he has not left his bed. He can't even sit up. So he's like, well, what is my life about? Why am I here? And so we work together on tools to give him something to look forward to. For example, he can use talk to text on his phone to write poetry. And I help him. I've already published 1 book of poems, and I'm working on a second one right now, because that is something he can do. But we have to help these people have a reason to keep living. That's how serious this is. The suicide rate is double the normal suicide rate in this population. And we will not know how many have taken their lives that never had a diagnosis, because as I said, they just don't want to live like this. There was a woman who was a writer on a popular sitcom years ago. When she got long COVID and she realized she wasn't getting better, she immediately took her life, because she was saying, I'm sorry, I don't remember her name or the sitcom or anything, because it's, back there somewhere. But she was saying, this is not life for me. So mental health wise, these people need a lot of support, and their caregivers have also sacrificed. I lost my health taking care of my son. I was expressing the frustration and the seizure and all these things. I got very sick. I actually have disability myself, because I could not take care of myself and take care of him without the kind of support that I now have. Now I have caregivers that come to the home. Now I have, a whole different kind of life. But at first, the first year, it was horrific. So we all need mental health support. I actually saw a therapist every week for a year, and that's what fixed me. I realized that my past was affecting my relationship to this sacrifice in my life, that I was constantly like, this shouldn't be. I want to divorce my son. I don't want to take care of him. And now I'm like happy every day. I wake up, this is my life, and I accept it. I make jewelry, when I have a few free minutes, and I make the best of, I take a walk with my dog and see nature, and I make the best of this situation, and I'm a happy person now. But it didn't start out that way. So these people need a lot of mental health support. And I don't mean, oh, everything's going to be okay. That's not the health support they need. Toxic positivity is one of the worst things you can do. And you're not going to find, oh, I'll pray for you or pray for me. You're not going to find that on these, ME groups, because these people have prayed harder than anybody you've ever met, and they're still sick. So the kind of support they need is, I hear you. I believe you. This is horrible. It shouldn't be like this. That's the kind of support they need. So that's my 2 cents.
I want to jump in really, really quickly and say that almost the most annoying thing that I have experienced and my daughter has experienced is the cheerleader type of support.
Yeah.
We don't need a cheerleader. We
No.
need somebody to get stuff done. And that's the piece of it's like if a caregiver wants to come in just to be a cheerleader, we don't need that.
Yeah.
And that's not coming from a place of like, we don't have positivity. We have a lot of positivity, but we need things to get done. And if you're not going to be able to do that, then please, we need to move on. And that piece of it. And one other thing is that people that have mild often become invisible. So they disappear for some time of their day or their week. So I just want to point out that people that have mild and moderate, there is no severity of mental health. It stinks just as bad for somebody that's mild or moderate because they're not being recognized and seen. So just because somebody is in a dark room and very tucked away our kids go unnoticed for long periods of time. I just want to make sure that the people that are mild and moderate also become recognized as having mental health crises also, but this mental health crisis is not the root of the disease. It is a secondary part of the diagnosis. So making their life more accessible is how you access mental health in these type of situations.
That is an amazing perspective. Thank you for sharing that. Melanie, do you have your hand up? Did you want to say something?
I just wanted real quick to say that there was a study that showed basically it's a wide range, but depression 32 to 70% and anxiety 32 to 57%. Now, it's at the end of the day, it's higher than age-related controls. So there's a higher incidence. And you're right, Amy and Galen, it's such an isolating disease, especially, well, really for everyone, but I always go back to kids. Kids and adults, they see their peers living life and moving on and going to college or getting married, having babies. So it is very isolating. But at the same time, again, like you all said, it's not the cause of the illness. I just want to make sure that's very clear. That's all.
We'll make sure to share out all these resources Talia put, for instance, a presentation that Galen did. So I'll make sure that that's all together. But thank you so much. I'll turn it over to Debbie.
No, that's fine. Yeah, you're really causing me to reflect on my advocacy capacity to advocate different perspective. Thank you so much. All right, we're now going to have Shauna Mahan from the Davis County Health Department, In-Home Services Bureau Manager with Senior Services. And she's going to be talking to us a little bit about that population and caregiving in that population. So go ahead, Shauna.
Thank you. I just want to thank the panel. That was just fascinating. That was so interesting. I'd like to just be able to sit here and think about it, but I have to jump on and do my part now. But I really appreciate learning about that, and I'm going to look into that more because that was really interesting. So I was just going to touch on some of the classes we have with Davis County Health Department Senior Services. And some of the classes we've just finished up with, and we don't have dates on the upcoming ones, but we can put that in the Google Doc or share it with Travis, and he can get the dates once we have those secured. One of the classes that we offer is it's called Dealing with Dementia, and it is a class offered through the Rosalind Carter Institute for Caregiving. It's a workshop-based class. We usually hold it, it's a 4-hour workshop, I believe, and it helps in the areas of understanding dementia, managing problem behaviors, handling stress, and finding time for you. And in that class, caregivers receive a large workbook or a guidebook that they can refer back to during their caregiver journey. That one, we just finished a class, I believe, last week or the week before. And this fall, I believe we're going to be having another session, and we can get, once we get the dates secured, we can find a way to share that. A second class that we offer is our Dementia Dialogues class, and I believe our main trainer might even be on the call. I don't see everybody who's listed, but I think Cheryl Knight is on, usually attends these. But this class is a 3-week course, and some of the just the highlights of the topics that they are covered are the basic facts and introduction to dementia, keeping the dialogue going with communication skills, preparing the environment, safety, ADLs, IADLs. Topic 4 is nothing personal, addressing the challenging behaviors. And topic 5, now what do I do? What do we do? Creative problem solving. So we just finished up a class with this. We're having another one at the Central Davis Senior Center in Kaysville in October. I don't think we have a secure date yet, but we can get that to you. This Dementia Dialogues is through the University of South Carolina, actually. It's a partnership with them. We have a new class that we're rolling out. Again, we don't have the dates for that. It's kind of a Caregiver 101 class. And this is for all caregivers that are caregiving for people with not only dementia, it can be any type of chronic condition, chronic illness that they're a caregiver for, and really of any age. Most of the people that attend are caregivers for older adults, but not always. We encourage anybody to attend. That covers caregiver basics, ADLs, IADLs, caregiver burnout, advanced directives. We also, through our department, we partner with the Alzheimer's Association. We have a dementia support group that's offered once a month at one of our senior centers. And we're trying to roll that out into Spanish here shortly. We also host a Parkinson's support group. So people that are working with care receivers that have Parkinson's, that is a group that they can attend. And then we do have some more fitness and education classes that really can help caregivers, care receivers, kind of any of those roles can attend some of our fitness education classes, and they're held at our senior centers around the county. And some of those are, we have an arthritis foundation exercise program, a bingo size program, chronic disease self-management course, enhanced fitness, a Tai Chi for arthritis, and a Walk with Ease class. So those are just kind of a highlight of some of our classes that we offer. I know we do a lot more, but those are kind of the ones that are geared toward caregiving and caregivers. So did I get anything from my team that's listening?
Or does anyone have any questions? You can put them in the chat, or you can come off mute.
Travis, were you going to say something?
Yeah, do you have a brochure that you could share with me, like an electronic that has these classes listed out? I know that it's always helpful for me as a visual person to see it all.
Yeah, we can put that in the chat. And then, like I said, once we get the updated flyers with the new dates of the classes, since we just finished up the series, we can find a way to share with those, and you can share those with your community partners or clients or whatever.
Shauna, thank you, because that information, we make sure everything that's shared here gets sent out to everyone who comes and participates today, because there's so much. We need to go back and relook. But all of those topic areas, Shauna, that you covered, we hear discussed often when we're working with individuals and families. And as we look in Davis County about supporting families through the lifespan, or our community through their lifespan, this is why some of this is so important for us to know as far as caregivers and support for our older population. So thank you, Shauna. Thank you for that.
You're welcome.
Travis, you are on as the Davis County Health Department Community Outreach Planner.
Yes, I just wanted to share a quick resource that my supervisor, Isa, sent me regarding open doors. So they are an organization that does a lot of things, but this particular resource, unfortunately, I wasn't able to scan the PDF. My scanner's not working at home today, so I'll make sure that's sent out. But there's a little flyer that talks about the Respite Crisis Nursery that's in Clearfield. So again, thinking about the lifespan, like Deb just said, not just for older adults, but how can we help caregivers or parents that are in need of some emergency care, and so that they can drop off a child for a limited amount of time and be able to get the things done that they need to, and to have self-care. So I like that their description, sometimes no matter how carefully you plan, the unexpected happens. When you need help and don't know where to turn, this is where our crisis nursery can help. During times of overwhelming stress or emergency, you can bring your child to the crisis nursery. We are committed to providing a safe, nurturing environment for all children in our care until your crisis has passed. While we are not a daycare facility, we are available to meet your needs when you need extra support. So they ask that people schedule in advance because their time slots fill quickly. And they also just mentioned, so what this is that you can schedule up to once per week in 3-hour blocks to give you the time you need to do some self-care, which is just a really important resource in our community. This flyer has the appointment times, the days, the times that people can ask for in slots, and they serve children ages 0 to 11. And let's see here, I want to mention anything else.
And Travis, can I just mention
Yeah.
how helpful that has been to be able to give parents this resource when they need self-care? But I'm amazed sometimes a parent I run into who may suddenly have a doctor's appointment or a court appearance and have absolutely no place safe to leave their child. And so this is when that crisis nursery can really be a game changer for them.
Yeah, so they say that there's a staff on call to meet after hours crisis needs as well. So weeknights, weekends, and holidays are reserved for crisis only, they say. So the rest on here is just kind of explaining the procedure, requirements, and things like that. There's also a brochure that I'll send out that's specific to providers. So this one's just the more generic one. But again, that was mentioned in the community health assessment, but it's not really right near the caregiving resources. So we thought we'd mention that as well. So yeah, that's all I was going to say about that.
That's great information. Does anyone have any questions about anything we've just presented here towards the end? I think if you have attended today, you have been enriched with a ton of information that's relevant to those who live in Davis County on many levels. And I love that the CHA keeps getting mentioned, and would encourage all of you to get your own personal copy of the CHA and take a look at it. Are there any other questions before we start wrapping up? No? That's okay. If you think of something, please put it in the chat or come off mute. I'm going to ask you guys to go to your emojis and just give this entire group a round of applause. Give our panel, our presenters, our perspective for Davis County. This is what makes that Davis Links so essential for us. See, there you go. Look at all the love and the hearts and everything else. So just want you to know how much we appreciate you being here. So in wrapping up,
Selena has a question.
Oh, I'm sorry. Go ahead. Go ahead. Who had the question? I'm not seeing it or hearing it, Travis.
Yeah, I'm not sure if she's
All
trying
right.
to talk or if,
All right. All right. Well, if you want to ask that question, you still can. But we'll go ahead and start wrapping up here with announcements. Do we have any specific announcements, Travis, that we want to share with this group?
I just put the link to the meeting evaluation in there.
Oh, yeah, please.
I think it's always good to, just as a reminder, to go to Davis for Health before as a number .org. That is where we post our community announcements. You can also go to the Google Drive that we share, and I share regularly in our emails. That is where some of the flyers are listed in that folder. You can also access previous recordings, materials. We also periodically send out the sheets that have the, when I say sheets, the Google sheets that list the members that are part of Davis Links that have agreed to share their information if you want to contact them. And we also have an ongoing list of presenters and their contact information as well. I know some people are newer too, so just a reminder of all of that, that the website has a lot of information that you need. But yeah, Deb's going to be the person doing the August forums. I'll let you talk about that.
Oh, okay. But I just want to emphasize that this information has been made so readily available for you. And this is your opportunity to connect with others and network. That's why it's called Davis Links. So next month in August, I remember the exact date, I'm sure Travis does, we will
It's
be,
August 27th.
and I believe this one is in person, right? We don't often have in person, but this one will be in person. So watch for that information. But I will be giving a presentation on the HOPE framework, which is health outcomes from positive experiences, which is a discussion about the other side of when we're looking at adverse childhood experiences and what we can talk about with regards to that. We often hear ACEs as being the negative side. The health outcomes for positive experiences will give you some language to talk about that in a little bit different way. So we'll be doing that in August.
Yeah, so that'll be held at the Farmington Davis County Administration Building.
131.
Basically where we always hold our in-person meeting, room 131, and you'll have that information. So yeah, we're not having a July forum, so enjoy your break.
Yeah, enjoy your July. Again, any other questions? I see lots of thanks in the chat and appreciation for all that you do in your work, in your job in Davis County. And we will look forward to seeing you in August.